Good morning. Welcome to this sponsored symposium by Abiomed. Let me introduce ourselves first. I'm Dr. Tin Nam Shui. Sitting next to me is my co-chair, Dr. Mike Cooley. It's my pleasure to introduce our speaker, Dr. Baba Basir. Dr. Basir is actually our friend. He has talked to us on many occasions before. He is from Harry Ford Hospital. He is an interventionist with expertise in various interventional procedures. Now he has great interest in the treatment of cardiogenic shock, especially in the use of mechanical circulatory support. He's a national leader in this aspect. And this morning we are glad to have him talking to us on the topic MCS options in biventricular failure, ECMO, Impella, and Bipella. Dr. Basir.
Thank you so much for having me. I really appreciate the fantastic opportunity. I enjoyed the HKSTENT session last year, and I'm happy to be a part of it this year. Thank you to Michael and the other organizers for including me. I hope this talk is useful and relevant to the audience in Hong Kong. So I'm going to talk a little bit about options of mechanical circulatory support in BIV heart failure. These are my disclosures. So when we talk about biventricular heart failure, really, because we talk so much about left ventricular heart failure, it's important to remind ourselves what the right ventricle normally does, which is that it's associated with the venous return. It is very sensitive to the pulmonary arterial load, particularly afterload. It gets affected by pericardial compliance. And then native contractility is based both on the right ventricular free wall as well as the interventricular septum. Now, the pathophysiology of right ventricular failure usually involves a higher CVP, right ventricular enlargement, a septal shift, and this intraventricular interaction really is an extremely important concept, because when we predominantly treat left-sided failure, we can forget about right ventricular dysfunction. And then the volume overload state will affect our hepatic function and our renal function, and is really an important cause of the multi-organ failure that we see in cardiogenic shock. So how do we define right ventricular failure? We can do imaging with echocardiogram, even MRI, to define right ventricular failure. But in the shock setting, when patients are acutely ill, the most sensitive and specific markers actually come from invasive hemodynamics. An elevated CVP, an elevated CVP to wedge ratio, a lower pulmonary artery pulsatility index, and a lower right ventricular stroke work index are all markers of right ventricular failure. And so it's really important to remember that this right ventricular failure actually complicates about 40% of what we consider to be predominantly left-sided heart failure with AMI cardiogenic shock. And these outcomes don't just affect AMI shock, but they also affect heart failure shock as well. And so the effect of the left ventricular hemodynamic support devices on the right ventricular hemodynamics and the right ventricular dysfunction has been somewhat less studied. And we looked at this a little bit in the cardiogenic shock initiative, and what we found was that, similar to prior work, that right ventricular dysfunction was common. It affected about 30% of patients who were thought to have predominantly left-sided heart failure from AMI cardiogenic shock. And what you can see is that those who had right ventricular dysfunction had a lower survival rate, in-hospital survival rate. And so there was about a 14% absolute lower survival in those patients who had right ventricular dysfunction. And so you can see on a scatter plot of wedge and CVP ratios that those patients who had high wedges as well as high CVPs in the top right-hand corner of the group actually had the lowest survival at 67%. So these are the sickest patients that we see in cardiogenic shock as well. I cannot emphasize enough why it is so important to use invasive hemodynamics and a pulmonary artery catheter to define this right ventricular failure, because this is the true way of helping to diagnose biventricular failure. And these are not like patients in the ESCAPE trial who were just sitting, warm and wet patients with heart failure, who mostly what you needed to do was afterload reduction and diuresis. These are patients who are very sick. They require mechanical circulatory support many a times, and these are patients who get benefit not only from use of Swan-Ganz catheter early on, but as Naveen Kapoor and the cardiogenic shock working group showed, that they actually get benefit by using a pulmonary artery catheter throughout the stages of their hospitalization, as you can see in their JACC heart failure paper on the bottom right-hand corner as well. Now, one of the things that we presented at TCT 2 years ago now was the fact that when you use a predominantly left-sided device like an Impella, and for those who do not use a Swan-Ganz catheter, which in the US is well over 60% of hospitals, then one of the things that is important is to understand that if you get recurrent diastolic suction alarms on the Impella console, that this is also a sign of right ventricular failure, because you can get continuous suction, for example, when your Impella may be malpositioned. However, when you get diastolic suction and intermittent suction, that this suction is associated with right ventricular dysfunction, and the more suction you have, the worse your outcomes are. And that's what we demonstrated in our TCT abstract from a year ago. So what options do we have in treating these patients? Well, we can add an Impella RP to a left-sided device for Bipella. We can add right-sided tandem devices, either with 2 cannulas or the preferred method in our institution, which is to use a Protect Duo cannula or dual lumen cannula. And then you have VA ECMO, the most widely used form of right ventricular support. Now, when deciding and choosing, it's really important to try to do so in a multidisciplinary, collaborative manner. And this was shown very well in the Critical Cares Network, that using cardiogenic shock teams is associated with improved outcomes compared to sites that have no cardiogenic shock teams. And so these are very complex decisions that a team of physicians should really look towards. So why is this important? Because these patients are the sickest of our patients. And so these patients are the ones who actually need the most support and the most collaboration to be able to get a good outcome. So ECMO is the fantastic device. It provides peripheral perfusion, oxygenation. It's very easy to cannulate. However, one of the downfalls of ECMO is that it has a double-digit risk of stroke, bleeding, vascular access complications, and from a pure physiological state, those patients with large anterior or large MIs in general, those patients who have very severe heart failure, it's much harder to recover those hearts when they're being loaded with the ECMO circuit, as you can see in this angiogram, because the ECMO is competing with the heart, and you can even develop north-south syndrome and other problems that we are well aware of. And so one of the solutions that has been best studied is to use ECMO with an unloading strategy. And this is particularly important in cardiogenic shock patients. And you can see on the right-hand side that this is not just in terms of AMI shock, but even in non-ischemic shock, this is really important. And so our friends in Germany, they looked at VA ECMO compared to ECPELLA, and they found that in a matched pair analysis, that those who had ECPELLA, despite having more vascular access complications, in fact had significantly reduced mortality with ECMO and with ECPELLA, excuse me. And so this is why it is so important to think of an unloading strategy when using ECMO in these situations. Now, we are less commonly using Bipella throughout the world, but in the United States, we do use Bipella somewhat frequently. And the advantages of Bipella are that there is a less associated complication risk. And if you look at this data and you compare the outcomes of adult cardiac ECMO and adult ECPR, to the data that was shared in the approval studies for both the Impella RP, whether they were involved in the Recover Right trial or not, you can see that there's much higher and much more improved outcomes. And a lot of this has to do with decreased complications because of the large bore arterial access that is needed in ECMO routinely, while the Impella devices are technically smaller. So I thought the best way, however, to share with you the complex decision-making that goes into choosing between these devices was to share a few cases. So this is a 50-year-old male, no past medical history, presented with 2 hours of chest pain, has a blood pressure of 70/40, heart rate 110, and had a cardiac arrest. He gets ROS, and this is his ECG. So the cath lab gets activated. He gets intubated. He's on 2 vasopressors, epinephrine and norepinephrine. He comes up to our cath lab, and as he has ROS, and then as soon as he gets on the table, he has a VFib arrest again. The team gets access, getting CPR, and in this case, this was a case from about 4 years ago. And so at that time, we did not have ECMO capabilities in the cath lab immediately. It took about 15-20 minutes for the perfusionist to come downstairs from the operating room to help us with ECMO. So the operator put in an Impella. There's clot within the left main, no flow in the LAD. The clot extends into the circumflex artery. The right coronary artery, as you can see, is relatively disease-free. The operator balloons and stents, and what you can see is that there's about TIMI 2 flow down the LAD. And so these patients very frequently have very high thrombus burden, and you can see that whenever you don't get TIMI 3 blood flow and a patient is sick, you really have to worry about what's going on. And so just according to the NCSI algorithm, the patient had a right heart catheterization, and that revealed very severe biventricular failure. Right atrial pressure of 21, his pulmonary artery pulsatility index was 0.48, his cardiac power output was 0.38, all demonstrating severe biventricular failure. He has ECMO placed as well in an ECPELLA fashion, and he actually has this placed, and the pressors are weaned off within 24 hours. His cardiac power output improves. This was all done in an expedited fashion. His door to support time was 53 minutes, door to balloon time 69 minutes. He was weaned off ECMO on day 8. He was weaned off of the Impella the following day. Now, he presented late and he did not have a good recovery of his left ventricle, but he was alive and discharged to rehab. The second case that I have for you is a 65-year-old female. She's hypertensive. She has 2 days of chest pain and fatigue, anterior Q waves, ST depressions. She had a mild troponin elevation at an outside hospital. Her ejection fraction was 15% with severe mitral regurgitation. She developed flash pulmonary edema, gets intubated, and was diagnosed with cardiogenic shock. She gets taken to the cath lab at the outside hospital, has a subtotaled LAD, has a severe constriction of all of her blood vessels, as you can see. She gets taken to our ICU, and what happens is she deteriorates here. She has on Levophed and dobutamine on her transfer. Her lactate starts to rise from 2.3 to 3.6. Her high sensitivity troponin is now greater than 20,000, and so she's having a full-blown MI. and clearly not doing very well on escalating doses of vasopressors and inotropes. We also take her down to the cath lab. We put a Swan-Ganz catheter in. We treat her with an Impella CP. And what you can see is immediately after the Impella CP is placed, her hemodynamics improve. Her right atrial pressure becomes 10. Her wedge comes to 16. Her PA sat is 59% with a cardiac power output of 0.9. So we would think to ourselves that yes, we've done our job. She's doing well, no problems. But one of the things when you see hemodynamics that represent biventricular failure, because when we started the case, her right atrial pressure was 15 and her PAPI was low, then we have a high suspicion of RV failure. And so in this case, we wait in the cath lab, we get further hemodynamics, in this case, 45 minutes later, and you can see her PA sat drops to 38%, her PAPI drops to 0.3. We place an Impella RP because of the RV failure. She had no problems with oxygenation, and she has very significantly improved hemodynamics that you can see on the right-hand side of your screen. So this patient then gets revascularized with stents in the LAD and RCA. She does extremely well. She also has some poor LV recovery. It does recover to about 37%. She never needs an ICD and actually does well for a number of years without any troubles or problems. And so a very good example of biventricular failure with Bipella. The last case that I thought I would show you is a 50-year-old man who has a long-standing ischemic cardiomyopathy, an EF of 20%, and he's transferred in decompensated heart failure to our transplant team. His initial hemodynamics are a right atrial pressure of 38 and a wedge of 50 with a cardiac index of 1.65. He came in very congested. He was intubated on the cath lab table. He was treated with biventricular Impella devices. However, after about 2 days, he developed some hemolysis. They were worried that he was going to need support for at least a week because he was still being worked up for LVAD and transplant. He did not have a good option for recovery. And during these first couple of days, he developed renal dysfunction as well as worsening oxygenation. And so what we did here is, you can see, is that we crossed the septum and we actually used LAVA ECMO to be able to support both the BiV failure and increased needs for oxygen. And LAVA ECMO is a bifenestrated cannula with a transeptal puncture, and it pulls blood from the left atrium and the right atrium. It rapidly unloads indirectly the left and the right heart, and we've had actually very reasonable success with this in our institution, and we've done this now about 40 cases, and we'll be hopefully publishing this more and more. But a very good option, and the advantage of LAVA ECMO over a traditional ECMO circuit or even an ECPELLA circuit is only the need for one large bore access, but it is still undirect in loading. And so in an AMI shock patient, because of the importance of direct LV unloading, my personal bias is still to use either Bipella or ECPELLA in those situations. So to conclude, MCS selection should be individualized to the patient based on shock severity, shock phenotype, guided by invasive hemodynamics. Clearly, it matters what devices you have available in your own country and throughout the world, and what each center is capable of doing. There's a lot of operator expertise and experience that are needed, and that is also balanced with the institutional's experience and expertise in taking care of these patients. So thank you so much for allowing me to be here. I'm happy to stay on and answer any questions that you have. Thank you.
Thank you very much again. A very nice talk as usual. So could I start with asking a question about the timing of decision making for the RV support? Because your first and the second case illustrate very well that the first case we decide for biventricular support immediately. In the second case, you highlight the importance of observation in cath lab for 45 minutes and look at the hemodynamic data after LV support. And then you escalate to biventricular support. And that is a practical situation that we are facing with those who are managing this sort of patient will understand. Some of our patients will just deteriorate after leaving the cath lab. After putting on LV support and then deteriorate, and then we find out that there is a biventricular or RV failure. So in your experience, what's the recommendation? You routinely observe in the cath lab for a period, or in your experience, do you still have cases that you need to escalate the right ventricular support after the patient has left cath lab? What is the experience, and how would you recommend us to make the decision in terms of timing?
Yes, this is a very good question, and it's very challenging because it really depends on what the initial hemodynamics are and where you think the patient is going. And so in the shock initiative, where we were looking predominantly at acute myocardial infarction, 80% of which were STEMI, the vast majority of these patients had predominantly LV failure. And so you have to be expedited in a STEMI. So we put in Impellas for left-sided support, opened up their arteries, and then put a Swan-Ganz catheter. And when you look at those patients chronologically over the first 24 hours, the vast majority of the time they decongest, and they don't actually need RV support. They do have right ventricular dysfunction, but it's not to the point that it's failing and they need support. So I think sometimes, rather than putting in 2 devices, you can put in 1 and give time to wait. But if you're going to do that, then it's really important to leave a Swan-Ganz catheter in so that you can continuously monitor that, and if they start getting sick, that you actually go down that road. The reason that we waited in this particular case, and the important point to emphasize, is that patient had right ventricular dysfunction and failure noted on the original Swan-Ganz number. Right atrial pressure 15, PAPI less than 0.5. And so the other argument that people sometimes say is, why didn't you just put both devices in immediately? Why did you even think about waiting? Well, if you want to be a little conservative, then what you do is you sit in the cath lab, you wait, and you see what direction their hemodynamics are going. And so a lot of this management becomes the art of taking care of these patients. But what is really important to keep in mind is the objective measures from a Swan-Ganz catheter to help make those decisions.
So if we have suspicions to begin with, it's better to observe in cath lab, but then otherwise we can still take the patient out of cath lab, but then we have to observe the hemodynamic and use the Swan-Ganz data.
Yes, and to your point earlier, we still see a lot of RV dysfunction happen, for example, after LVAD, right, durable LVAD. And sometimes you don't notice that right after the operation. Sometimes, it waits 2 or 3 days before it kind of manifests itself and these patients start doing poorly. And so as long as you're monitoring for it and have a good suspicion for it, this is the most important thing.
My last question is, Barbara, thank you, this great talk. You mentioned about lava ECMO. So when you see patients with biventricular failure, how do you decide when to go for Bipella support, or how do you decide when to go for lava ECMO?
Yes, great question. And so I think it depends on the expertise of the faculty there. That a transeptal puncture I think is relatively easy. I don't do structural heart procedures, but even for myself, it's not too challenging. And so I think that becomes one aspect of care that we have to look at. The other most important aspect is oxygenation. If you need to support somebody with oxygenation, I think using an ECMO then becomes mandatory. When you don't do that, then I think it's probably okay to use a Bipella strategy. The only problem with the Bipella strategy is that just like any other circuit, the blood is going through two pumps. And if it goes through two pumps, there's always extra risk of hemolysis. And so that's, if you're only doing it for a few days, my go-to strategy is Bipella. But if you're gonna leave the device in for more than a few days, or that's what you anticipate, then I think going with the Lava ECMO is a better option. But we know that there's a lot of more complications with ECMO because of vascular access and stroke.
All right. Thank you again, Barbara. Hope to see you in person very soon.
Thank you. Thank you. Have a great conference.
Thank you. Great day. I would also like to announce the winner of the first case competition dealing with something unexpected. The winner is Dr. Cliff Lee from Tan Tock Seng Hospital, Singapore. And his case is follow the right path. Congratulations, Cliff. That ends the session here, the sponsor session by Abiomed.